I'm Alexandre Belot. I'm a professor of pediatrics in Lyon, France. I'm doing pediatric rheumatology, and for the year, I'm part or member of the executive committee and also responsible for the lupus registry. So I have the chance to be the head of a department where we have pediatric nephrology and rheumatology, dermatology, which sounds good for lupus clinics. And as part of the GL Lupus working party, I think this experience and skills are very important, and the collaboration with all the specialties specialized around the lupus lesions, especially nephrologists, is critical. So we are lucky to have this single unit with all this expertise. In the daily practice, it's extremely useful. We have a daily discussion on how to manage the patients with the lupus nephritis, and it's a joint effort to give the best treatment we can to the patients. An important changes we have now in the daily practice and even in routine, it is that we can better analyze the cause of the disease. And that makes sense in pediatric practice because we already know that about 10% of GSLE are driven by a single gene mutation, for example. So now, as a routine procedure, we have started to screen all GSLE patients for genetics to check whether or not there could be a single gene that explain the cause of the disease, because here you will have a specific treatment to propose in case you have a given mutation. Then we have also a lot of new biomarkers that are coming up, and probably more reliable than what we did in the past with just the anti-nuclear antibodies, for example. Part of these new biomarkers we have set up in Lyon the interferon signature as a routine exam. We are doing this at the diagnosis, but then we follow the patients with this interferon signature. Interferon signature, it's blood exam that we are running. We need cells because it's an RNA assay. We are doing this by nanostring. We use 6 different ISG to screen whether or not there is this interferon circulating, and interferon is closely associated to the activity of the disease, so I think it's very important. And in GSLE, it seems that interferon is always increased, at least at the beginning, and the goal is to decrease and drop this signature as much as we can, and we see it's parallel with the activity of the disease. Sure, actually, as it's now a routine exam, you just can ask and send it to Lyon on the routine base, and you get the answer after around two weeks. Meaning that for France, we are running about 2,000 ISG a year, which is quite important. I think, yes, it's one of the single place I know where we have set up this as a routine exam, but we help others to set up this assay in their own country or their own city. We are now aware that Paris, Lille are starting this procedure, and we have some plan to develop this in Belgium with some colleagues. We are doing this in parallel to help them to set up this exam as a routine practice, and we are happy to do it with anyone interested in setting up this procedure. In terms of therapy, I think if the biomarkers, the genetic can help us to decide how we can treat the patients. And it's a bit different from what are doing our adult colleagues that are treating essentially the patients depending on the lesion or the kind of disease. If there is skin involvement, if there is kidney involvement. I think in the future, and particularly in GSLE, we will have to cope with the genetic factors, how they can explain the disease, and then how we can combine treatment that is efficient for this cause of the disease. And the biomarkers will also be critical to follow how we can treat them. So as I mentioned, interferon signature is particularly increased in pediatric lupus. thinking that probably this new target upcoming as anifrolumab, for example, is very promising in the field of lupus nephritis. We already use JAK inhibitors with some success in the lupus. And another even more exciting situation is the upcoming of the CAR T cells, because all of us are all very aware of what happened in the work of Georgette Erlangen in these lupus patients. But what is very important is to say that all the 5 first patients that benefit from this treatment were 18 to 22, but all of them started the disease at the adolescence, meaning that this disease, which is more severe in the youngest, in adolescents, could be treated by CAR T cells, and we have not a lot of follow-up. But after 2 years, the lupus patients have no more treatment, no more double-strand DNA, normal complement. So it's really impressive, because for the first time we can think about something that can be cured, not only a long-lasting treatment. So we have really a lot of hope regarding these strategies, and I hope that the international community on pediatric rheumatology will start early this procedure to test this on pediatric lupus patients.